Welcome everybody to today's Penn AI Tech webinar. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, an initiative funded by the National Institute on Aging. And I'm very happy today to welcome Dr. Yuri Quintana to be our speaker for today's webinar. Dr. Quintana is a global leader in developing and evaluating digital health systems. He's the chief of the Division of Clinical Informatics at Beth Israel Lahey Health, and he's assistant professor of medicine at Harvard Medical School at Harvard University. His research is focused on learning networks and clinical care collaboration platforms that empower patients, families, and health professionals. He leads the DCI network, which brings together national-level leaders to work on complex health problems. And he's also developed InfoSage, a mobile app for home-based coordination for medication and symptom management. He has an extensive record of research and industry partnerships and really impressive work. We're very happy to have him today as our speaker. I want to remind people that they can post their questions using the Q&A box at the bottom of their screen. And at the end of Dr. Quintana's presentation, we'll have time for a few questions. So with that, Yuri, thank you again for joining us today.
Thank you very much, George, and the Penn AI Collaborative. I really appreciate the opportunity to share the work that I'm doing with colleagues, not only here, but across the United States and Canada. So we'd like to describe the work that we've been doing to sort of bring more technology for homes, particularly for older adults. And some disclosures. We're going to talk about a website called InfoSage. It was developed with U.S. federal research funding, AHRQ. We do have some funding from Pfizer. I'll mention a project that Pfizer mentioned, but there's no commercial association in terms of the study. We were free to sort of do that research and publish freely the results, which I'll share with you today. Any other commercial products that will be mentioned are purely for illustrative purposes and no endorsement is implied. And we do work with the VA, Veterans Administration, on telemedicine. And any mention of that project reflects my own views and not the views of the Veterans Administration or the US government. So what are the major challenges that we face? And I think we have a growing elderly population worldwide. Almost every country will have more percentage of their population that will be 60 years and over. And we actually have a lower fertility rate than in previous generations. So we're going to see more and more older adults. And as we live longer, we're also living with multiple chronic diseases. And so managing multiple chronic diseases means multiple healthcare providers, multiple medications, and higher levels of costs. And these costs are now becoming a real challenge for the stability of the economies of most countries around the world. We also have a shortage of healthcare providers, both physicians, nurses, social workers, mental health care providers. So then the demand for services is increasing at a much faster rate than the number of people who are graduating from these professions. And not everyone that graduates from these professions goes in the side of healthcare provision. Some of them go into the private sector or other non-health services delivery side areas. So we have more and more people and less providers per capita. And we also have a very, very fragmented system where as you get older, you likely are going to see more than one provider, more than one specialist. You're accessing data from multiple sources of information, and you're getting your prescriptions and medications and other services from multiple providers. So how do we help connect all of this ecosystem and make it more useful? And it's been recognized that coordination of care among all these providers is a major challenge across all the developed countries. And for the less resource rich nations, this problem just isn't there because they don't have enough providers, but they would have the same problem if they were to have more funding for healthcare services. And so a nonprofit group called Leading Age in 2017 published sort of a visionary report that urged more integration of services, particularly for older adults, that would incentivize and promote information sharing and would help provide better ways to support telehealth and focus more on wellness as well, and with a strong emphasis on chronic disease management. And while this document was visionary, it didn't actually specify the details of how to implement it. And so going forward to today, we still have this major challenge of a very fragmented system. And I'm going to focus on a few things that are causing tremendous problems. One of them is how to actually safely use medications. And by law, when medications are dispensed, you need to have one of these information pamphlets that are approved by the Food and Drug Administration, the agency of the US government. And this is true in almost all the other developed countries as well. The problem is that this document contains all the information that is legally required, but it's often printed in 10-point font. There is a standard. It's a brief standard. It's only for print. And unfortunately, one of the things it says is you shall have this in no less than 10-point font. And people have sort of by practice used 10-point font, even though for most people, that's actually not very readable. So this is not readable both on the font size and also the word choice. And if you look at the labels that come with the actual package on the outside, it contains minimal information, but you don't have a QR code that takes to a website that has more easily to understand information. And why is this a problem? The problem is that only 12% of Americans, 12 to 14%, are proficient at a level that is necessary to understand that. And 14% are at a level that's considered below basic proficiency, which means that they cannot understand even the most basic instructions that are on the medication. This is also true of their inability to understand other directives of how to care for them at home. And then, if you start adding just basic, you get to about a third of the population that is at a basic or below. And the interesting thing about this is that there really hasn't been a national study in over a decade. So these citations are a bit out of date, but that's because the US government has not funded a national study, but individual smaller studies have also indicated that we are still at that same low level of literacy across our population. And drugs are becoming more increasingly complex, which have more and more side effects. And so if you see this is from this paper, it shows some of the potential drug-drug interaction effects. And so while they're listed in that document, trying to make sense of this is very difficult, not only for the patient, but also for the healthcare provider. And we know from multiple studies that non-adherence to medications can account for up to 50% of treatment failures. And it costs the system both in terms of added costs, hospital readmissions, and at worst case, preventable deaths. So this is a huge problem. And there are many reasons why people stop taking their drugs, but we don't have a really good way to communicate with patients once they're at home to understand why they stop taking their medications. In most cases, they have some reasons for that. Maybe they get side effects that they don't understand or are intolerable. Maybe the dosage was wrong for that particular patient. Maybe there are some drug-drug interactions with their other medications, but we don't have a really good way of collecting that information of what happens at home. We see people when they come in to the hospital, they do an inventory of all the medications. Most of the time, people have trouble remembering all the medications that they may have bought. They may not have brought in all their medications to the lab visit. So understanding what people are taking and why they're stopped taking it is a major problem that's causing a lot of challenges. So over a decade ago, our division started to look at how to develop technologies to help older adults. And we started with a project called InfoSage Health. And I want to give just a word of thanks to our founder of our division, who founded the division, Dr. Howard Bleich and Dr. Warner Slack. And you see Dr. Warner Slack here, founded the division in 1970 here at Beth Israel Deaconess Medical Center, with a strong view on patient-centered computing, which is very visionary at the time, wasn't very popular. And they said that the most underutilized resource in healthcare is the patient. And I think that's still true today, because patients have a lot to tell us about why they stop taking their medications, what side effects they have. but we're not collecting that data very, very well. And so to this date, I think we need to involve patients more. And so this project followed that same sort of ethos in that we created from the very first days, a discussion with patients and their family caregivers to understand what are the challenges that they have in providing care. And for many of us who have older parents, we're having all of this challenge of how to do this sort of caring coordination. And so what we need to do now is to really, give me 1 second, please. Thank you. So what we need to do is really understand what are the dynamics of communication, not only between the provider and the patient, but with family caregivers who increasingly are more involved in care coordination. And we need to understand what are the preferences of patients and be able to respect them. Oops. Apologies. Let's start this again. Okay, so we developed this project called InfoSageHealth.org, which is a private social network where a patient and their family caregivers can create a private network to manage all their medications and when they're supposed to take them, and allow both the patient and the family caregiver to work together to sort of help manage those conditions at home. It has educational resources. It has a way to list task management beyond just taking your medications, such as when are your next visits to the healthcare provider. And you can actually also add your healthcare provider to the network. And it's been challenging to do that, not because of the technical point of view, but healthcare providers are time limited, and there are some other technology and privacy issues, which I'll get into later. But for the most part, it has been used by hundreds of families across the United States to be able to manage at home. Second, make some trouble advancing the slide. Let's try this again. There we go. And we designed it not only in cooperation with the patients, but we also worked with nursing homes and nurse home aides and different hospitals and some private sector companies to understand how do we develop technology that is appropriate for the family and meets their needs. And what we found out is that they really wanted to have a really good way for them to communicate between the multiple family members that were caring for that patient. They wanted to be able to understand their medications. They wanted to make it easier to update their medications list and be able to access authoritative sources. And so we created a set of educational resources that were vetted by healthcare providers. And we decided to sort of look at how to build that interface to manage those medications and try to communicate those medications very clearly. One of the things that they told us that they want to control who could access their information. And so we created a layered level of access. And depending on the family member's role, they could access different types of information. And what we also realized in 2014 is that even though phones are pretty prevalent, the use of that phone when you go beyond 75 starts to decrease. And it's not just whether you have a phone, it's how you use it. And so using that phone for apps and healthcare apps can become quite challenging. So they'll use it for maybe a phone call or FaceTime, but using it for healthcare applications was harder. So we wanted to improve the usability. And so we developed a set of principles. And one of them was how to help control the privacy and access that was family-centric. And I'll show you those layers in a moment. They wanted to be able to manage their tasks as well as be able to search reliable evidence-based information. and be able to understand their drugs and drug-drug interactions. So I mentioned that we had a layered approach for access. So the keystone is the main patient, and that patient can then assign a proxy. That's a trusted family member who will have access to all the information in that system. You can also have a caregiver who can be able to see the medications but not edit them, and be involved in other tasks such as providing services at home. And then we also had a list of tasks that family members could volunteer to participate. And then finally, we had a level of participation where you could get basic high-level information about the patient, be able to send a message to that patient, that keystone, or volunteer to do certain tasks. And so the keystone and proxy would set up the network, and then invite other caregivers and friends to the network. Here you see some of the web-based interfaces for this. You see some of the different tasks. This is a fictitious person, so it's not a real person. And the medications are just for examples. But you'll be able to see what are the active medications that the person is on and what are some previously inactive. We also built a mobile app, and we went through several iterations of improving the usability of this app. And we've published on both the methodology of those usability tests as well as the improvements that we made to the interface. And over a series of multiple iterations, we were able to significantly improve the usability of the app and the website to the point that both the majority of keystones and non-keystones, keystones are being the patient or the elder, were able to use the app. And here you see that the logins were almost a little bit higher for non-keystones, but still significant for the keystones themselves. In terms of medication management, the keystones were more actively involved in looking at their medications and recording information about that. And in terms of tasks, it was mainly non-keystones that were involved in signing up or creating tasks and doing tasks. But overall, the majority of the patients were able to use it. We also noticed that the usage of the app was somewhat episodic. So every once in a while, when there was a change in medication, there was a sudden spike in medications, and you'll see some of those spikes there. What we also notice is that it's really hard to introduce this technology when something really difficult happens in the family. So if they haven't been using it and they get hospitalized and they're about to be discharged, at that point, if it's the first time that they've had an episode of something, even though we gave them the information, it was very hard for them to sort of deal with new technology at the time. So an ongoing open question is, what time and place is the best to introduce this technology? Because a lot of times people don't think they need this technology until they need it. And then when they do need it, they're under too much stress to do it. So most of the families that came on board when there wasn't an acute critical situation. But we still need to do more research to understand when's the best time to introduce and motivate people, incentivize people to get set up before they actually have a serious crisis. We also looked at some patterns of when people were accessing this, and this is all the users. So you'll see that people used it throughout the weekdays, a little less on weekends. And we also see that these are different types of networks that were created between patients, caregivers, and participants. And we found that there was just a very broad range of networks. So there wasn't one type of network that predominated, neither in terms of the structure, in terms of what percentage were keynotes, proxies, or caregivers or participants. And we also found that geographically, they were all over the place as well. So some were more Boston-centric, but Boston's a big city. And even within a big city, it helps to have a technology like this that allows you to stay up to date currently. And then we had other families that were spread out throughout the United States. What we concluded over a decade of this work is that you could build an electronic family network and increase the usability of this. And the enrollment of families has also been geographically spread out. So it's not just something that's useful in urban or rural areas, it's useful in all kinds of settings. And through improved usability, we were able to increase the use of it. Like I said, most of them were able to use it, but at some point, sometime when they're 80 or over, it becomes increasingly difficult to use any type of technology. And so we started exploring voice-based interfaces, and we did a prototype with Alexa, where you were able to sort of interactively ask what medications you were on, when was the next time you'd have to take a medication. So we did a proof of concept. A big challenge of this is sort of what is the security of that data. And so we never deployed this publicly, in part because at the time, Alexa didn't have an agreement which would allow us to ensure that they would keep the data secure and private. Since then, some of these other AI providers have started to provide that type of legal agreements. But that's an ongoing concern as to who audits them to make sure that any data that is shared with these providers is not accidentally or intentionally shared with others. We also did some deployments of this in other parts of the world, and with Dr. Jack Lee, we did a deployment of this in Taiwan and translated to Chinese. As we move forward and we try to figure out how to scale this up to more and more people, there is the issue of patient equity and how to make sure that as we make all these advancements with better technology and sensors and voice-based interfaces, that they become available not just to the rich and well-to-do, highly literate, both tech literate and health literate, but make this affordable, accessible to all patients. And so I think that's going to be one of the major challenges, because otherwise what we're actually doing is increasing health disparities. We're creating great technologies, great medicines, but if we only make them available to those that can afford them in urban centers, we're really creating a growing disparity of healthcare and healthcare outcomes. And so with that in mind, about 2 years ago, we started developing a better approach to improving the health, on the ability for people at different health literacy levels to understand their medications. And we did this project funded by Pfizer to be able to improve the display of information to patients. And so we created a new version of InfoSage, which allowed us to sort of increase the font size, the color, but also the order in which and the format and how information was displayed. And so here you see on the right an example of a medication, but it has a button for you to be able to play an audio, and it will actually read you the label, or you can put a button and it can show a video of this. This is just a prototype. It wasn't deployed for patient care use, but we did a usability study with patients who are at different levels of literacy to understand how well they benefited from these improvements. And what we found is that all the patients, whether they were at high levels of literacy or lower levels, found one or more improvements that spoke to them, that helped them understand that information. They did also feel that the way in which the information was organized and the icons could help improve the information. There's still much work to be done in this area, though, because if you want to tailor the content to the individual patient, you would need to know the medical history of that patient and maybe flag certain sections. So for example, if there are certain concerns, if you're taking this and you're diabetic or you have cardiac issues, you might want to highlight those warnings for those types of patients based on their clinical history. So integration of these types of interfaces is really important. I'm part of a European consortium called Gravitate that's looking at this very issue of personalization of the label. And we've also started a group here within our division called DCI Network, which is a consortium of both patients, providers, patient advocates, and private sector people to figure out how to create new standards for how we display digital medical information. And the FDA recently asked for opinions on this topic. And our group of about 50 people met over 4 months, and we submitted a response to the FDA with recommendation, somewhat informed based on the study, but also we had a symposium at Harvard in June last year, and we just recently submitted those recommendations. Sadly, in the United States, there is no standard for how to display electronic medical medication information, and that's something that I think is badly needed. Not only for the display of that information, but as we get into things like chatbots, I think we're going to have standards for how we make sure that those discussions that happens with chatbots are securely held and not used in a way without being transparent to the user. And I'll talk more about that in the next half of this talk. So what are the next steps for InfoSage? We want to continue to make improvements to not only the display of that information with text, graphics, and video, but start to get into also chatbots. We want to be able to make sure the technology works regardless of which device. So we'll continue to do usability studies. And we really need to do more testing, whether particularly those people in the bottom third of health literacy can truly understand that information. Because if they don't understand how to take their medication or why they're taking that medication or what are the side effects, these are reasons that may contribute for them to either not take their medication or inappropriately take their medication. Maybe they'll stop taking a medication, then all of a sudden they'll start it at a dose that really they're not ready for and may have adverse effects, or they'll double up on medications. And so being able to understand and explain this to patients properly and be able to understand their questions will be critically important. So how do we create that link at home to be able to understand it? And so this leads to sort of how these devices, technologies could collect symptoms, adverse events, questions they have, and be able to report this back to providers. The question is, where do you store that data? How do you, not only from a technology point of view, but who will manage that data? Who will review it? Who will act on it and make sure that people get their questions answered? And if people start reporting these adverse events. Legally, you do have to, if an adverse event is reported to a provider or a pharmaceutical company, they have the legal requirement to submit it to the FDA. And from what I can see, they take that very seriously and they report it usually within 24 hours. The problem is that not all that data is actually even being reported in the first place. And we need to provide more ways to report that information and be able to do something with that data. Which leads us to sort of the next sort of evolution of these apps is to how do we then make a home a smart home, a home where we can have multiple devices that allow us to collect health information, be able to empower patients and families to manage that data, and be able to understand how that data is being used by elsewhere, and how do we provide value to patients and families, value that helps them manage those medications better, manage their health care at home, and improve. So I'm going to give you quickly just some of the types of examples of applications that are being done. There are many of them. This is just a sample of them. And they're now being used to have wireless and wearable sensors that connect to apps. There's this term called Internet of Things, which are very small devices, could be cameras or other things that can collect data. And there's a whole science called Internet of Behavior, of how to understand how people behave and how to motivate them to more safely take medications and follow directions, and how to incentivize patient behavior. And there's a variety of technologies apart from wearables that can be used. There are interactive decision support systems for patients. And there are cameras that can monitor your movements. For dementia patients and other patients, they can track your movements and see if there's a decline in how often you move. There are people listening to voices to see whether how you enunciate changes over time, and that might be an early indication of neurological problems. how to connect insulin delivery and track diabetic levels at home, how to use inhalers for asthma. Asthma is a growing problem for many people. And how to then connect all of these devices that people are selling in a way to aggregate that data that allows you to analyze it. So there are a ton of companies putting out products. And one of the problems that we have, I think, is that we have a divergence of technologies and data formats. And while there are some standards to be used, there really isn't a consensus set of standards that people are focusing on. So there's a growing sort of problem with all of this. And so there are companies that are now trying to create ecosystems and platforms that integrate this. And while this is important, I think we do need to have more discussions such that each of these platforms share a set of core standards that they're all using, and also how those data are being collected. So I'll give you just two examples of things that are not standardized. So the drug dose form, right? Dosaging can vary greatly. And we did some analysis with another consortium called Unicom, comparing how the Europeans represent dosing with the Americans. And there are differences between the two. One is more granular than another. And I'll point you to the paper by Natalie Karapetian from our group, who described the differences between that. When people actually take medications is important as well. And so how do we track in a consistent way when people took those medications, when they missed it, and what are the reasons for why they didn't take their medication? The taxonomy for reasons for non-adherence hasn't been agreed upon. And so while there are some standards, such as the International Patient Summary and FHIR for connectivity, we still have several layers of interoperability that we're going to have to develop. So the other thing is that we need to test which of these devices give you clinical grade quality. The FDA has been testing some of these devices and has cleared some of them. It's not that easy to find which ones have been approved. To go to the FDA website, it's actually pretty darn hard to find which ones have been cleared. And some of the companies are abusing this title. Some are saying they're FDA cleared and they're not. So it's sort of buyer beware right now. And so we do need to have better standards for transparency of what actually has been approved for clinical grade, as well as what are the standards for how that data has been collected in terms of privacy and security. So let's start with the positives. The positives that if we build this ecosystem, we could build a more smart remote monitoring, where we could have a more complete view of the patient at home in terms of what data what health data is trending for them, and be able to provide alerts and recommendations for that. It could give us enough data to sort of do early diagnosis of onset of different diseases. It might be able to help us predict strokes. It might be able to understand how to modify medications for things like Alzheimer's and dementia. But all of this really depends on having quality data that is consistently collected with the right level of granularity, in the right level of consistency. And we can make this data accessible to those that will have the ability to analyze it and improve it. So what are the problems of these platforms? One is the unauthorized access of that data by hackers. And it's an ongoing problem, but it's actually an increasing problem. So if you look at the number of cyber attacks on healthcare providers, it's been increasing. Both the energy sector and the healthcare are sort of rapidly increasing in terms of target. And so we need a way to test and validate whether the security on these systems is safe and valid. We did a webinar, which you can go to the DCI network, which talks about whether these devices are being transparent about what data they're collecting in terms of, particularly with audio. And there are some devices that are actually listening to you all the time. So this talk was called "Are My Devices Listening to Me?" And we have an outstanding set of panelists who work on different aspects of privacy and security, and encourage you to look at that. But what came out of that is that really there are a lot of different ways in which that technology could be properly used, but also improperly used. And we need some better standards for how we describe how that data is being collected, what it's being used for, and who tested that system is actually complying with that standard. We also need to make sure that as we collect this data, that the data, when we go to do these predictive models, was sufficiently rich in terms of diversity of patients, in terms of their clinical history, gender, race, ethnicity, such that we have models that are actually representative. And if there are limitations, we should be able to describe what those limitations. So if we have an AI-based system that was trained on all this, a label should be able to describe, or a paper should describe what data was used to train that. With colleagues, I've wrote this paper that talked about how to build from the get-go, when you're designing these AI-based systems, a way to document to make sure that you have enough data and that any concerns about bias and equity are transparently communicated as you develop and evaluated this. And so this follows a traditional software engineering development process, but what it does that adds to that is at each step how to reflect on issues of bias and equity that may implicate the overall final system. And so this sort of recommends what you could do at each stage to make sure that you reduce the problems of bias. You will never fully eliminate all of bias because you can't collect all the possible data, but being mindful of the limitations of your data and being transparent, I think, is a really important step towards earning people's trust. We also need to make sure that as people use these systems, they don't overly rely on these systems and think that just because something says it's AI, it's been validated and it must be true because, well, it says it's AI. And so we need to educate people not to be over-reliant on some of these technologies and have the human element to verify what the systems are recommending. There's also the potential negative effects of psychological effects of feeling over-monitored. And, you know, as one of the important things for older adults is to have a level of autonomy. And so how do we introduce these technologies and make sure that that we're not actually increasing anxiety on people because we're monitoring them and perhaps they felt pressured to accept all of this. So how we introduce this to homes is really important to make sure we don't have negative psychological effects, which sort of brings us to this point of transparency, that whatever you build and how you implement that AI probably needs to have some clear disclosure that describes in full transparency how data is being used, how it's analyzed, what are the limitations of the system. And a lot of AI systems, when they make a recommendations, don't actually explain why they're making that recommendation or what it was based on. And so we held a conference here at Harvard in September on AI. And if you go to the DCI network, you can see the program and some of the talks. That conference looked at what are some of the issues in healthcare in AI. And one of the things that resonated really strongly is the issue of transparency. And how do we develop some way for AI systems to transparently describe what they're doing and how they were built? And so that is ongoing. We have a working group of over 50 people developing some practice standards. We have some papers coming out. And if you're interested in this issue of transparency and validation of AI, let us know. We're happy to get you involved in this group. And finally, about equity. As we develop all of this technology, how do we make sure that it's not just benefiting one sector of the population? How do we make sure that the funding is available to make sure that this reaches all people? And so maybe that's providing financial support to people who can only pay partial the cost of a smart home. And maybe there are grants to cover the rest. Just the way we do with internet access, we provide financial supports. Maybe we need to develop a health policy to bring this to another. And I think we also need to be able to identify what are the standards that we want to use, such that we can create smart homes. And there's a few industry groups that have started to coalesce to try to agree on that. And I think we need to have some synergy between these multiple efforts, such that we don't have 20 efforts sort of with 20 different strategies. So we really need to sort of coalesce down to fewer groups that are doing this, but with more uptake of those standards. And this gives you an idea of sort of what are the levels of standards. It's not just technical sharing of data, but it's also how do we structure that data at a syntactic level. And so those are sort of the data schemas that you might want to have for that. And then there's the semantic description of what is in those data models. And that's where you get things such as SNOMED, LOIC, and RxNorm. There's one level of semantic that's not in this chart, which is a newer addition, and that's called a knowledge graph. You know, what does it mean to be poor or lonely? If we're going to be able to reason with this data beyond using neural networks, but be able to have systems that use symbolic reasoning to be able to reason with that data and generate explanations for recommendations that can be justified and understand the implications and the meaning of content, we need that knowledge layer. And I've been in this AI business for several decades. There was a term early on called brittleness, that something can be really smart in a very narrow domain, but it can't go beyond that domain because it doesn't know anything about the external world. And so as we talk about things such as social determinants of health and other things like loneliness and other clinical factors that don't have a very good current data structural representation, we're going to have to develop this other layer called the AI semantic layer to be able to do reasoning. So I think probably in the next 10 years, we'll see many of these knowledge layers. Some people have been working on this for decades. It's a really hard thing to do in a way, but it's a really important part for AI to be explainable. And so with that, I want to sort of start just reflecting on what we would need to have a model of a smart home with generative AI, that if we wanted to have a system where you could talk to the system about what drugs you were on, why you were, and you'd be able to tell it why you weren't taking your medication and why, what are the potential side effects. To have these conversations, we're going to have some pretty smart chatbots that not only understand medicine, but understand human elements of empathy. And we've already seen that some chatbots have shown better empathy than humans, but I think it's a really rich area to sort of develop what are the human factors for AI in the home. So in the future, I think we need to build patient-centric models that are absolutely co-designed with patients and family. Before we run off with thinking that we've got a great hammer and a new neural network and build things that we think people want, we should, right from day one, be talking with patients and their families as to what they really want. We need to understand how that smart home connects to the healthcare provider world, and how do we actually create reliable personalization that is meaningful to the values and preferences of the patient, but also is evidence-based and doesn't recommend something that isn't based on hard data or the best and latest evidence. And so that personalization and the validation is going to be very difficult to do, but it must be done so that people don't just take a recommendation for something that has a label called AI that hasn't been tested or validated. We're going to have to make sure that this technology can work for different types of people at different both technology literacy level, health literacy level, and economic levels. And so how do we adapt and create different solutions for different types of people? We're going to have to stop inventing new standards and just improve the ones we have and try to have more consensus. And finally, I think probably the most important part for AI is that we're going to have much more disclosure about what these AI systems what's inside the box, how it was built, what data was trained, how that data is being shared and used. And we need some best practices. And some of these best practices probably will need to become policies and laws. I think at this point, our group that met in September feels that we need to first begin with best practices and get consensus on it. And then maybe a year or two from now, decide which one of those needs to become hard policies and laws. But this is moving very quickly. And I think transparency and safety needs to be priorities for them. And with that, I just sort of, my final recommendations is that we really have a great opportunity to bring AI into the home. We have to prioritize giving control of that data to patients. We need to rigorously test for bias and inaccuracies. We need to improve the usability, verify the privacy, and make sure that whatever we do, we're giving feedback and opportunities to all kinds of users to make sure we're solving their needs and being inclusive. So I think with a balanced approach of including patients, having transparency, we can create ethical AI and help build trust with patients, families, and providers, and create a great system. With that, pretty discoverable on the internet, and happy to answer any questions now after the event. Thank you.
Thank you so much for this great presentation. I know we got a lot of questions, and also a reminder for those who have questions to use the Q&A feature to add their question. Maybe we'll start with the first one. We have a question about the InfoSage tools. Are individual InfoSage tools designed to allow a local care coordinator to aggregate records for oversight of several patients? This would have to be low cost, able to communicate with providers' EHRs, and easy for individuals to use.
Yes, you can build. We did build a FHIR connectivity that allows you to extract the data into a medical record. So we did a proof of concept with connecting it to a medical record, major medical record system. When we went actually to do it at large scale with a healthcare provider, the concerns weren't so much about technical. There were some technical concerns. For example, we allowed, we didn't necessarily have two-factor authentication, but that's pretty easy to add. We allowed for you to authenticate with Google Mail. They didn't really like that. Well, we can take that out. So most of the technical issues, we were able to sort of come up with a solution. The part that we weren't able to solve is sort of who's actually going to be looking at that data, right? And be responsible for that. So if you're collecting that data and it becomes part of the official medical record, you have a responsibility to monitor that data and act on it. Similar issues have come up with patient portals where they'll put an ad saying that if you put in this data, you shouldn't use it for direct patient care, that if you have an urgent issue, call that. So you could put that label on that repository. But there is a big concern as to whether that data that you collect, even if that database is inside your hospital firewall, who's going to manage and actively look at that data? And so that sort of brings up the issue of reimbursement and accountability and compliance. So if someone's going to look at that data, that's time that needs to be reimbursed. And so who does that and who gets paid? How do you bill for that? And then how do they then communicate to other people who needs to work on that? So there's an internal communication, right? Is it a mental health issue? Is it a pharmacy issue? It's a nursing issue, a physician issue. And so we haven't really had a good way of reimbursing that. Very recently, I think in December, the US government decided to finally fund cancer care navigators, which our hospital has had. And these are people who help patients navigate the cancer system and act as an advocate for the patient. Our hospital has paid out of our own pocket for those positions for a long time. And we've had published studies showing the benefit of that. So finally, now we're getting reimbursed for that. But I think we need to have a care coordinator that's reimbursed, particularly for older adults who have multiple healthcare providers who often don't communicate with each other. And sometimes they prescribe something for that patient that inadvertently affects another condition that they're battling with. And so I think insurance companies and Medicaid and Medicare really need to start funding that. I think nurse and and physician assistants and others could fill that role. Doesn't have to be a physician or necessarily a nurse, but you can have people trained to do that role, but it's gonna have to be reimbursed for this to get scaled. So I'm sure we can figure out the technical issues, the reimbursement and getting people to accept the role of that coordinator will be a really big challenge.
Great. We have a few questions around artificial intelligence. One comment says, as a clinician, it would be great to know what goals of care the AI tool is aiming at, whether it's longevity, function, quality of life, and that takes into account the patient's preferred model of shared decision-making and how they process data. So that way I can know the tool is being used for them and not at them. And then following that, there's also a comment about transparency and wondering if what your opinion is about whether AI is providing an explanation to their output may actually increase users' dependence to AI. So I guess both of those comments have to do with how you see AI working in the clinical setting in a way that you think would be flexible enough to address different clinician and patient preferences.
So I think both of those questions speak to the need for AI to have explainability. So when it gives a recommendation, why? So, and there's one is, how did you come to that conclusion? What sources of evidence and what goals you were trying to solve? And why, if there are multiple possible choices, why are you suggesting one over the other? That explanation and even the dialogue that needs to happen after that explanation is given for clarifying questions isn't really part of current day AI systems. And I think it'll need to be there. That's something that you have with a human when well, most people have that. If you have a great provider, not everyone's as welcoming to your people's questions, but in an ideal sense, with a good human provider, they over time get to know your preferences and take these into account. They can have a discussion with you over, and so sometimes, for example, some people may want a different type of treatment, even though it will shorten their life, but give them better quality of life over the next 6 months to attend certain family events, weddings, or saying goodbye to friends. So in some cases, their interest isn't longevity, it's quality of life for a shorter period of time. So that dialogue isn't there right now with AI systems, and so I think humans, I think, can use AI and be that conduit. But the problem with, even for the provider using AI, is that they can't get from the system, from most systems, the rationale or the options that were in what priority. And so I think that's something that AI will need to improve upon to be able to get more traction with and trust with both providers and patients.
We have a couple of questions that speak to the fact that the commercially available solutions keep coming up in the market. The Consumer Electronics Show hosted in Las Vegas next week has an entire track on health, aging, technology, including day-long sections on psychology and tech. And given that there is this growth with commercially available solutions, there's another question that asks, is there a trend for patients to pay out of pocket for some services like remote monitoring, AI care assistance, and so forth, as opposed to only relying on insurances to cover those?
So yes, there's a plethora of technology out there. The evaluation of the technology is sadly far behind. So it's sort of buyer beware of what you're buying into. A lot of the big insurance companies or payers won't pay for something until there's validated evidence that something works. And so that's going to be a rate limiting factor for these companies to get reimbursed for their services. And I'm hoping that more of them will actually commit to doing trials and evaluations, especially with third-party evaluators, so to have more confidence in the results. So I think that's an opportunity for groups like AAMI and others to do the evaluations for these companies at a distance and have the ability to sort of report the results. Now, I think the FDA, you can submit things to the FDA to get approved. And the FDA, if you're using your device, whether it's hardware or software, for diagnosis or any type of recommendation, you actually have to submit it. And so some of the workarounds that these companies are doing says, well, we don't recommend you use it for actual recommendation. It's just, you know, as an educational tool. Well, but in practice, people are using it as a recommendation tool. I'm not sure for how long this loophole can continue. And probably until there's some big disaster and people are going to say, okay, if it looks like and feels like you're making recommendations, you have to submit it regardless of what your marketing company does. And so I think the lack of evaluations is going to be a problem for getting these reimbursed. Now, like I say, you could buy them, these services, and with the disclaimer that they're not, haven't been vetted by the FDA or your insurance company. And it's really kind of buyer beware there as to whether the recommendations that come out are actually valid or not. And so, yes, there is a very rapidly growing market for that you can buy not only from products from the USA, but worldwide. But many of these haven't been vetted. And so people may actually be doing more harm with some of these. So the only advice is to be buyer beware. I understand that if you need help and you can't get it, it's not reimbursed, you might want to buy this. I've considered some of this myself, but you really need to question who has tested it to make sure that the advice that's being given is accurate, and also that your data is actually not being resold and that your privacy. And so this is another huge problem, is that, you know, you may be giving away a lot of data of your name, address, your health condition to other people.
I guess we have time for one more question. How do we measure AI transparency? What would be considered acceptable level of explainability? Would that be qualitative or quantitative? AI trust has been a big challenge with clinicians when the AI model recommendations differ from their case management team's assessment.
So there's a lot to peel out of that. That's a great question. So in terms of what's in the box, one of the things our group of 50 people are doing is sort of coming up with sample labels that we're going to put out in a paper for discussion for whether that label for different types of products has the information that people would trust. We would then have to actually test it with people to see if that label is actually sufficient to earn trust. And I think what we're going to have to do is have more active engagements with patients and providers as to what they would like to see to be able to trust AI. And I think those communications aren't particularly strong. And so, for example, the FDA, the NIH, and other agencies, I think have been thinking about doing more outreach. They've done some calls for commentary. They're setting up some panels for advisors. But I think both industry and the government are going to need to sort of reach out more to find out what people's concerns are. Because I think once we get over the hype cycle, which we're on right now, it's like a sugar high. It's like AI is great. Once we start seeing bad recommendations and bad outcomes, the hard questions are going to come. And I think we do need more panels that involve providers and patients at the forefront of these policies, not as a token gesture at the end.
Great. I know there's more questions. Unfortunately, we're running out of time, but please feel free to email Dr. Quintana directly for any follow-up questions or more conversation. I want to thank you, Yuri, again for this great presentation that stimulated a lot of questions and discussion. And thank you all for attending. We are recording this presentation so you can view it in a few days on our YouTube channel, where you can see all the recordings for our webinars. And our next webinar is on February 1st with Dr. Sean Mooney from the University of Washington, talking about artificial intelligence initiatives at UW. So thank you again, Yuri, and thank you all for attending, and I'll see you next month.
Thank you. Take care. Bye-bye.